Hi, my name is Todd. I'm a home health nurse, and our company is moving over to um, IA assisted charting. And I'm in the process of learning how to do this voice out loud assessment talking, and thought as I'm learning it that I would just kind of do a short video for other home care nurses to kind of help learn this sequence if you're going through the same thing as I am. So this is a naturally speaking framework. While assessing patients, the goal is to help nurses verbally capture clinical thinking in real time so that AI can generate a strong Medicare safe narrative note. I'll be kind of looking over at my notes as I go through this. But anyway, the first thing you do is introduction to the patient and kind of why you're doing this and that you get their consent for the recording. And so you say something like this. Hi, I'm going to complete my assessment while talking through some of what I'm observing so that I can make sure that I can document everything accurately for our healthcare team. And then, so the opening clinical summary would be something like this. Patient seen today for skilled nursing visit related to diagnosis of whatever it might be, whether it's CHF, diabetes, COPD. Patient remains homebound to whatever is keeping them homebound. Increased weakness, and then skilled nursing continues to be medically necessary for ongoing assessment, education, medication management, and monitoring for potential complications. And then we move into the general observation. So as I enter the home and observe the patient sitting either on their chair, in the couch, whatever it might be, patient appears alert and oriented to person, place, time, situation, or whatever they might appear to be, and home environment appears safe or it could be unsafe due to animals or whatever the situation might be. And then patient appears in no distress, or they may have mild distress related to maybe their breathing situation or whatever the case may be. And then caregiver, uh, you can verbally say whether they're present or not present. And then we move down to the vital signs talk track, and vital signs obtained and reviewed. Blood pressure today is like 120 over 60, which would be good. Heart rate, whatever that is, respirations, temperature, and oxygen saturation. And then you talk about how if the vital signs are within normal limits or if they're abnormal. And then also some findings: patient denies dizziness, chest pain, worsening shortness of breath, or acute symptoms at this time. Then we move on to the uh, pain assessment side. And this is where patients will report, but we use a scale between 0 and 10. 0 is no pain, 10 is the very worst pain. And document verbally, where the location of the pain is and the description of what the pain is, whether it's an aching, burning, sharp, dull, throbbing, or intermittent. Um, Pain worsens with whatever's causing increased pain, usually of moving around and doing things like that, and improves with, well, medications or rest. Um, and then current pain management interventions reviewed, including medications, positioning, rest, and even some non-pharmacological management plan. And then we move on to the cardiopulmonary assessment portion. Lung sounds assessed, breath sounds clear, diminished, or crackles, whatever you find, and you describe what lobes they're in verbally. Um, Patient denies increased shortness of breath, or they may have a productive cough or chest discomfort, and you just talk about that in your verbal narrative. And patient demonstrates dyspnea with exertion after ambulating, say 10, 20, or 50 feet, and cardiac assessment completed. Edema noted or not noted in the lower bilateral extremities, whether the heart rate is regular or irregular. And then you verbally say patient educated on signs and symptoms requiring physician notification, including worsening edema, rapid weight gain. We usually do 3 to 5 pounds in a week as a thing. Also, one thing I also do encourage them to do is to put a calendar in their bathroom, and so when they go and weigh themselves, they can put the number in the calendar. Um, and then say patient educated on signs and symptoms requiring physician notification, including worsening edema, rapid weight gain, chest pain, or respiratory distress. Then another segment is the diabetic assessment. Blood sugar log reviewed to see where they've been trending, and patient reports blood sugar readings ranging from, say, 90 to 180, whatever it might be, and then also verbally talking about any signs or symptoms of either low blood sugar or high blood sugar observed during the visit. And then diabetic foot assessment is completed to see how their lower extremities are, especially their feet. And then patient education regarding diabetic diet compliance, medication adherence, and the importance of monitoring, blood glucose consistently. And then we move to the wound care track, and this is where you would verbally talk about the wound assessment and what you find, where it's located, what kind of drainage you might find, and if the description of the drainage, whether serous, sanguineous, or purulent. And then no signs of infection observed, including redness, warmth, odor, or increased drainage. And then wound care performed per physician's orders, and then how the patient tolerated it. And then education reinforced regarding the prevention of infection or when to report complications. Then the medication review, medication reconciliation completed, medications reviewed for effectiveness, compliance, and potential side effects, and how the patient reports, whether they're compliant or not compliant with the medication regime, and any adverse reactions reported during the visit or what they might have said throughout the week. And then education reinforcement regarding medication schedule, the purpose, and the safety and signs and symptoms of reactions. And then functional homebound status. Patient remains homebound due to what is keeping them homebound: weakness, impaired mobility, fall risk, shortness of breath with exertion, pain, or the need for an assistive device and caregiver assistance to leave home. Leaving home requires considerable or taxing effort is what we're looking for to remain in the home. Patient ambulates with either a walker or a cane or even a wheelchair and requires supervision or assistance. And then fall prevention education can be reinforced during that time. And then skill need for justification. This is always important for the OASIS. Skilled nurse remains necessary for ongoing assessment and monitoring of the disease processes, medication management, cardiopulmonary assessment, patient education, and early identification of potential complications requiring interventions by the skilled nurse. Without skilled nursing intervention, patient remains at risk for hospitalization, worsening conditions, and medication complications and falls and disease exacerbation. And then we go ahead and verbally, capture the patient's response to that education. Education provided regarding, the disease process that they're experiencing, and patient verbalizes understanding through teach-back method. And then additional reinforcement needed regarding how they reacted to that education and learning. And then the visit summary plan. It'd be nice if there was no acute changes requiring physician notification at this time. Patient instructed to notify the agency or physician for worsening symptoms, and you can give some of the examples. And then the next skilled nurse visit to focus on continuing assessment, education, medication management, and monitoring. And then patient left in stable condition at the end of the visit. All this is verbalized. So, the AI dictation best practices for nursing that I would like to leave you with here is speak like you're explaining the patient to another nurse. Avoid robotic phrases. Instead of patient okay, you can say something to the fact of patient demonstrates continued weakness with ambulation and requires frequent rest periods with minimal exertion. And always state why you're there, what you assessed and what you observed, and what skilled care was performed, and why the patient remains homebound, and why nursing is still medically necessary for the patient, and what education was provided, and patient response to those interventions. I'd like to leave you here with the golden rule for AI narratives. If it wasn't spoken, AI cannot build the clinical story. The stronger your verbal clinical reasoning, the stronger the AI generated Medicare safe documentation can be. Well, if you made it to the end of this, I appreciate it, and we'll see you on the next one.